Good evening. Welcome to this Ask the Expert event focused on hematologic cancers. Tonight, a panel of experts will share helpful information about cancer screening, diagnosis, and treatment. We will also answer your questions live. To submit a question for our experts, simply drop it in the chat here on Facebook. Let's meet our panelists. First, we have Dr. Naveed Mokhtari, a board-certified hematology and oncology specialist with Northern Virginia Hematology Oncology Associates. From the Mary Washington Healthcare Regional Cancer Center, we have Whitney Christie, a board-certified specialist in oncology nutrition. We're also joined by Mindy Dorsey, a registered nurse from Mary Washington Hospital's outpatient infusion therapy. Next, we have Deanna Benoit, a cancer nurse navigator with the Mary Washington Healthcare Regional Cancer Center. And finally, we have Ted Schubel, local radio personality and cancer survivor. Welcome, everyone. Thank you so much for joining us this evening. Dr. Mokhtari, I'd like to start with you this evening. Could you kick off the program by defining for our viewers what hematologic cancers are, how you diagnose them, and how you treat them?
Sure. Thank you, Emily. Technically, we have only few hematological malignancies. If you want to just be very simple, we can categorize in lymphoma, leukemia, and myeloma. But we have tens of leukemias, well, probably more than 50 types of lymphomas. And we have a multiple myeloma, which is also categorized into a few types. What are they? Leukemia basically is a cancer of white blood cell, but we should not think about only white blood cell involved, because cancer means overgrowth of cells. And when white blood cells are produced in large number, they kind of pack the bone marrow, and there's no more room for other cells to grow. So definitely you will get anemia, which means that low red blood cell, and thrombocytopenia, which means the low platelet count. So these are the features of usually blood cancers when they're involved in the bone marrow. This is what we usually see in leukemias. On the other hand, lymphomas are the cancers of lymphoid tissue. Usually they start from the lymph nodes, which we call it nodal lymphomas. But when it gets advanced, it can involve a lot of areas in the body, including the bone marrow, and can be associated with abnormality in the blood cell count. Myeloma is a very specific type of cancers, specific to plasma cells, which is one subtype of white blood cells. And overgrowth of those cells in the marrow can be associated with anemia, means low red blood cell. It can be associated with lytic bone lesions. So a lot of these patients may have features in the bones like a mouth-eaten bones. And this overproduction of plasma cells is associated with increased protein levels in the blood, and that can cause kidney dysfunction, and sometimes can cause increased calcium level. But going back to leukemias, we have two major types: acute leukemias versus chronic leukemias. Acute leukemias usually are life-threatening conditions if they're not getting treated within a few weeks, while chronic leukemias may not even need to be started on any medication. Most of the time we just observe them, and we only offer them treatment when basically the disease causes symptoms. Lymphomas, most of the time, we just divide them in two categories: low-grade lymphomas versus high-grade lymphomas. High grades is the ones that are aggressive, needs immediate treatment. A low grade, again, we may just observe them without treatment. The other question is, how do we know that we may get these symptoms? A lot of patients with lymphoma, leukemia, or myeloma may not have any symptoms until the disease really get established. And a lot of time, primary care providers, they just pick it randomly on their routine blood work while they don't have any symptoms. Sometimes they tell the patient, hey, it seems like your white blood cells out of normal range. Do you have any symptoms? The patient said, no, I feel fine. And then they refer it to hematologist, and we usually do some tests to find out if there is any primary blood cell abnormality going on, and then we detect that. And those cases are really good because we jump on treatment very early, and the outcome is great. But some of these aggressive lymphomas or leukemias, high-grade ones, they usually have immediate symptoms that I'm going to talk about. The symptoms of blood malignancies are generally called B symptoms, and B symptoms comprise of extreme fatigue, the level of energy that you cannot get out of bed, drenching night sweats. It's not just sweating because of hot weather. I mean, this is when other people in the family feels fine and you feel like all the sheets in the bed gets wet. Or unexplained fever or chills. There is no infection going on, but you don't know, your temperatures are rising. And also unexplained weight loss. These are the main features of blood disorders, blood cancers symptoms. The question about the screening tests on these blood malignancies. Unfortunately, guidelines, they don't tell us any recommended screening test for lymphoma, leukemia, or myeloma, but family history is really important. If they say that they have a lot of family members that develop these blood malignancies at a young age, that kind of tells us that we may need to do some more investigation early upon finding a certain associated symptoms. We're not randomly screening patients would have a positive family history for any blood malignancies. Usually patients have some abnormality either in the lab or clinical pictures. But what are those screening tests? Basically depends on the case. If it's a blood malignancies, we usually do flow cytometry or some of the gene profiling we check. And for the lymphomas, a lot of times we may get a CT scan. Usually we try to include the neck, chest, abdomen, pelvis, which give us the whole panel of lymph nodes and organs that can be involved in hematological malignancies.
Thank you.
Sure.
So, so we've talked about, some really important information about symptoms. So by the time a patient has symptoms, they probably see their primary care doctor, and then they would be referred to someone like you, a hematological specialist. What kind of treatment might you recommend for a patient who presents with a hematologic cancer, and how would that patient prepare for treatment?
Sure. Like I said, it really depends on the grade of that blood cancer. If it's a high grade, usually needs a treatment. A lot of chronic leukemias or lymphomas or low-grade lymphomas, they may not need any treatment. We just treat them for decreasing the symptoms. One of these B symptoms that they have, they're suffering from extreme fatigue. We try to fix that. Or enlarged organs, enlarged lymph nodes or spleen, would try to shrink them because those enlarged organs may cause other symptoms. They may push on the urinary tract, cause urinary obstructions. They can kind of put pressure on the airways, causing shortness of breath or other symptoms. So we try to treat the symptoms. But low-grade lymphomas or chronic leukemias, the reason that a lot of times we don't treat them is the treatment intent for those blood cancers are not curative intent. So the treatment is designed to control their symptoms while improving their survival outcome. On the other hand, aggressive lymphomas, high-grade lymphomas or acute leukemias, the intent of treatment is curative. So we offer them chemotherapy, immunotherapy, or targeted therapy. I'm going to talk about them. The goal is to eradicate cancer, although still a chance of recurrence, but the goal is to make them cancer-free and enjoy the rest of their life without dealing with the cancer anymore. For the low-grade lymphomas or chronic leukemias, a lot of time, because we cannot eradicate cancer from the body, the goal is to just alleviate the symptoms and improve their survival. We'll tell them upfront that, hey, this is a treatment that, try to help you. If you don't have symptoms, if I don't see your lymph node enlargement is going to cause any problems, I better not to treat, because we cannot cure your cancer. What we are doing, basically, we're improving symptoms, and we should not expose you to these chemo agents with a lot of side effects while there is no cure benefit of these kind of cancers. Based on the type of cancer, the treatment might be different. Most of the blood malignancies, the treatment includes chemotherapy. And the chemotherapy agents are usually cytotoxic, which means that they suppress the bone marrow production. A lot of cancer cells are dying, but also a lot of immature cells in the bone marrow, they may not survive. So that's why you will get bone marrow suppression during the chemotherapy. So usually we tell the patient you should be prepared for this aggressive induction chemo. You may lose your hair, you may become severely anemic and fatigued, but this is going to be a temporary symptoms, because the duration of treatment for most of these curable cancers are usually 6 to 12 months. And we'll tell them, like, after you finish this course, we'll recheck you. If your cancer goes to remission, we'll stop, and all the side effects will go away. Immunotherapy is not as bad as chemotherapy. How immunotherapy works, basically, is we try to unleash the immune system to go ahead and find the cancer cells and eliminate them. So immune cells are basically lymphocytes, B cells and T cells. Those are normal immune cells in the body. They already know that they should fight the foreign cells or agents in the circulation. We'll try to tell the immune cells that they have to be hyperactive and go and search more and find the cancer cells and try to eliminate them. That's how immunotherapy works. But immunotherapy usually designed to work on a specific markers on the cancer cells. For example, most of the lymphomas, B-cell lymphomas, have CD20 markers on the surface of the cells. So we have this agent like rituximab, which is the agent that is specifically made to go and attach those cells and eliminate them. So a lot of immunotherapies are tolerable. They don't have that much bone marrow suppression or cytotoxic side effects. So people can tolerate them much, much easier and better. Usually, we don't have pure immunotherapy treatments for the blood cancers. We usually combine with the chemotherapy. We have targeted therapies specifically for agents that we know about their gene mutations. And nowadays, all the cancers are all about genes. Acute leukemias in the past, we used to treat them with 2 or 3 types of cytotoxic chemos. Nowadays, before starting those treatments, we have to make sure what type of acute leukemia they have, and if their leukemic cell express a certain cell marker. If they have those, the patient is lucky. Sometimes they can skip the chemo and go directly to the targeted therapy, which is most of the time is much more tolerable. A lot of time that targeted therapy, which usually pills. Most of the targeted therapies are pills. Some of them are injections or infusions. Most of the time, they're pills and very tolerable. Usually, we add them to chemotherapies, and so basically, this is the mainstay of the treatment of blood cancers. First, we need to know what type. Is it acute? Is it chronic? Is it low grade, high grade? And then we'll design the treatment based on that. Like I said, it really depends on the side effect profile of those chemo or treatment agents. And based on those, we prepare the patient or what they should expect from this treatment.
Great. Thank you so much for that information. It sounds like patients have a lot of options open to them depending on their specific diagnosis. You mentioned chemotherapy, and I'm glad that we have Mindy here this evening because she works in the Mary Washington Hospital outpatient infusion therapy. And so, Mindy, can you tell us a little bit about infusion therapy and what role it plays in a patient's journey?
Sure. When a patient is diagnosed and their treatment plan is established by the hematologist or oncologist, if the patient is uninsured or underinsured, they typically will come to Mary Washington Outpatient Infusion for the service. When they arrive, we make them feel comfortable. We typically start an access of some sort and draw their blood. A lot of the patients will have an implanted Metaport for infusion services. Once we receive the blood counts, we'll tell the pharmacy to make the medicine, and then we'll also contact the navigators and the dietitian. We do screenings for both of those to make sure that the patient's getting the total picture taken care of. When we have the counts back, if there's anything that's an issue, we contact the physician's office or the physician directly to make sure that the patient doesn't need any type of further transfusion prior to their chemotherapy. Depending on their regimen, they can spend an hour with us or they can spend the whole day with us, but we try to make it as pleasant an experience as possible, and they get to know us very well. So typically we'll be a trusted resource for them throughout their journey. And if they need something, they'll come to us first, and then we can share it as needed to whoever really needs to have the information.
Thank you, Mindy. It sounds like infusion therapists work across a patient's continuum of care with their other specialists and providers to make sure that they're getting really a holistic treatment. Mindy, you know probably better than anybody that Mary Washington Healthcare really strives to understand and meet patient needs. And I understand that you were part of a project to help expand hours of service for blood and platelet transfusions in outpatient infusion where you work. Can you tell us a little bit about what that means for patients in our community?
Sure. So a lot of patients who are going through any kind of chemotherapy, doesn't even have to be for hematologic cancer, require transfusions throughout their treatment. With the schedule that we had, we would be booked for everything up to a week in advance. When you need a blood transfusion or a platelet transfusion, you typically need it the same day or the next day. So looking at our staffing and our scheduling, we were able to see that if we just added 2 more hours onto the end of our day, we could accommodate almost double the amount of patients. And we could also get patients in for same day transfusions as long as they were identified early in the morning. So instead of patients having to go into the hospital to the observation area or go into the emergency room for their transfusions, they're typically able to be seen with us either the same day or the next business day. So it's made a big difference for our blood transfusion dependent people.
That's wonderful. Thank you so much, Mindy, and we really appreciate your work on that project.
Thank you.
So I'd like to spend a little bit of time chatting with you, Ted. Of course, we know your voice from the radio, but some people in our community might not be aware that you are a cancer survivor. Can you tell our viewers a little bit about how you learned that you had cancer and what your journey was like?
Yeah, Emily, I was the kind of person who there was no cancer in my family, and I never really took it all that seriously. I knew when I got to be 50, I knew that I needed to have a colonoscopy, and I put that off for a year. And my story is really about screening, of how mine was discovered through screening. And it was I had a doctor in, and I was interviewing a doctor on colorectal cancer awareness month, and I asked him, speak to the person who's kind of a little bit nervous about this. knowing that that would be me. And his answer was, give me 24 hours and I'll give you 5 years. And to me, that clicked. So I made an appointment, got a colonoscopy, and it was during that colonoscopy that he was able to see through the colon wall something that didn't look right. Turned out to be a lymphoma. And that's where my journey began.
Wow, that's wild. So it was kind of an unintended consequence of a colonoscopy, but that colonoscopy still saved your life, even though it didn't find colon cancer.
Oh, it did totally. And then I was introduced to another sort of an aspect of all of this, of where when initially the prognosis would be that I would be treated and have chemo from roughly July to late spring. And it was during a Mary Washington healthcare conference where doctors get together and would discuss all of this. They all looked at my case that was really in the early stages. I had no symptoms, nothing. And they looked at that and determined that my cancer was much more aggressive. And that changed, it changed it completely. And so I was treated basically from July to December very aggressively. And it turned out that it was a very aggressive form of cancer. And so, yeah, but I think the screening showed it. It was the conference then, I think, that ultimately saved my life.
Thank you, Ted. And we have a question coming in from a member of our audience asking if cases are reviewed by multiple oncologists. And that's what you just mentioned, right, Ted? So that cancer conference where multiple oncologists come together to review a patient's case and discuss possible treatments to really achieve the best outcome. And Deanna will be able to talk a little bit more about that later on in our program. But before we move on, Ted, as a cancer survivor, what wisdom and encouragement would you like to share with members of our audience who may be facing a cancer diagnosis?
To me, I set goals. And I had a friend who had said to me, we were talking about a particular hockey player who was under cancer treatment. And the day he had chemo, he scored a goal. He said, so what can you do? And I determined then that I was going to work every day. And I did that. I never told anybody about that. And it wasn't always easy. But for me, setting goals was a huge thing. And that was my goal, to get up. And sort of near the end of it, I know my doctor had said, had noticed that he had heard me on the radio every day. And he said, I knew at times you couldn't be feeling as good as you sounded. And he said, I just wish more patients could do that, or would be able to get up and do things. And so my days weren't always as long, and I had shortened days, but I determined that I would get up every morning and go to work. And I did.
That's wonderful and great advice. Thank you for sharing that, Ted. So Deanna, Ted mentioned cancer conference, and we've already gotten a question about it from members of our community who are watching. So as the cancer nurse navigator, can you tell us a little bit about the cancer conferences that happen at Mary Washington Healthcare?
Sure. Yes. The cancer conferences, we meet 3 times a week, and we discuss different cancer types. We have a multidisciplinary group of the medical oncologist, radiation oncologists, surgeons, support people. The navigators are there, the genetic counselors are there. And we look at each individual. We try to see all the new diagnoses. We look at each individual patient and review their case, look at the images, discuss the pathology report, and everyone discusses the treatment planning for this patient. So it truly is, we really appreciate all the input from the different medical oncologists. They give input into patients that aren't theirs, but they're seeing and presenting. And the primary oncologist or the surgeon will be the primary person presenting the case. So that is definitely a huge advantage to our team. And we really do work collaboratively with all the members, all of our specialists. We really appreciate their inputs. Another group that we have is our hematologic malignancy work group. And we actually have a separate group from the cancer conferences that consists of medical oncologists, pathologists, the lab. We have infusion nurses there. We have the inpatient world represented, the assistant nurse and the nurse manager of our oncology unit. And we discuss issues and we try to problem solve and make recommendations to improve the care of our hematologic malignancies of our patients that we're serving. So yes, as you said, I'm one of the nurse navigators, and we provide services to patients at Mary Washington, at Stafford, and to the community. As a navigator, we come alongside of patients with a new diagnosis, an existing diagnosis, or patients even that have suspicious findings that will need additional workup. Our goal is to guide patients through the healthcare system, and while we're doing that, to remove any barriers to their care. We educate, do a lot of education. We provide psychosocial support. We like to meet patients early in their diagnosis so that we can establish a relationship, so patients can have a face with a name and know who to call when they have difficulties. Another part of my job is I do see patients inpatient. So shortly after patients receive a diagnosis, we meet with them and try to identify any barriers to care that they may have and assist them with that, providing psychosocial support. At the Cancer Center, we have a team of resources that do all of this, and services that are provided. We have a dietitian, and Whitney's here with us tonight, and she's going to talk. And we have a genetic counselor. We have a licensed therapist. We have different support groups. We have an integrative medicine program, the nurse navigators. We have a survivorship program. All of these services are free, and they are on our website. And if there's any patients that or any people out there that need support going through their cancer process, please just don't hesitate to give us a call.
Thank you, Deanna. We've had one of your colleagues, Ashley Sisson, on these programs in the past, and you both just speak so well to the role of the nurse navigator, and to really be an advocate for patients and to walk alongside them during their journey. So it's always a pleasure to hear about the work that you're doing for our patients and for our community. One of the benefits that Deanna mentioned that falls under the Mary Washington Healthcare Regional Cancer Center is nutrition support. And so we're very excited to have Whitney Christie here. Whitney, when we started the program, we saw a lot of letters behind your name, lots of credentials and certifications. Can you talk to us a little bit about what those mean and how it helps inform your work with our patients?
Sure. The first certification that I have is a certified specialist in oncology. This is a specialty certification that is available to registered dietitians who practice over 2,000 hours with oncology in the oncology setting. And then you have to take an exam and pass that exam to get that certification. So that's one of my certifications. And the other certification that I have is my certified nutrition support clinician certification. That is a certification that is available to dietitians, doctors, pharmacists, nurses who work with individuals who have feeding tubes and or are on IV forms of nutrition. And a lot of our, quite a bit of individuals in our community do have feeding tubes or are on IV nutrition who go through various forms of cancer treatment.
Thanks, Whitney. Can you tell us a little bit more about some of the nutrition care offerings that are available through the Mary Washington Healthcare Regional Cancer Center?
Sure. So I do individualized nutritional counseling, and I can do this since COVID-19 happened. My services have changed to what I call telenutrition. So those are services that are available virtually. They can be done by video. They can be done by telephone. I also do electronic forms of communication with patients. In terms of what the visits entail, that would be individualized to the patient that I am seeing. So, for example, example. I call them kind of the before, during, and after treatment nutritional needs. So in terms of before treatment, I might have patients that want to improve their diet going into their cancer treatment. They may have different comorbidities such as diabetes, high blood pressure, that they want to learn how to manage, and they want to optimize their diet or learn more about what their diet should be like. There's also, different forms of cancer treatment, as Dr. Makhtari was explaining, and those there are different side effects that are related to those forms of cancer treatment. So, for example, patients can have issues like taste changes. They can have issues with nausea, vomiting. They can have issues with diarrhea, constipation, and they may be at more risk for malnutrition. So what I do is educate patients on different side effects that this is before treatment that they may expect that are highly associated with the forms of treatment that they're receiving. In terms of during treatment, I may get individuals referred to me who are having issues with nutrition during treatment. So again, they may have lost weight, they may have different challenges that they're dealing with, such as managing side effects, and they just want a little bit more nutrition advice. And then I also talk to patients after treatment. So those visits typically we talk about survivorship. So we talk about things like healthy diet. We talk about exercise. We talk about ways that they can improve their nutrition and that they can be a survivor. So I really enjoy those appointments with patients because it's kind of looking forward to the future and looking for a better self and looking to improve their nutrition and improve their health. And then there's other resources that are available to patients. So I have cookbooks, I have recipes, I have a lot of access just to different resources. I can also help patients with kind of navigating things that they may see on the internet. I get a lot of questions about kind of different myths that are out there about nutrition, or my friend said this about nutrition. Should I be avoiding these types of foods? So we talk about those different topics as well.
Thank you, Whitney. We do have some questions coming in from our live audience, and I want to make sure that we have an opportunity to speak to those. And Whitney, one of the questions coming in is for you. So if someone is undergoing cancer treatment, is it possible that they would lose their appetite? And if that does happen to a patient during treatment, how can their loved ones help them keep their caloric intake up?
Sure. It's very possible that you could lose your appetite during cancer treatment. That can happen for a variety of reasons. So there are, again, treatment-related side effects that can affect that. So a lot of times when people lose their appetite, I try to find out why they may have lost their appetite. So I'll ask questions about, are you having any side effects related to your cancer treatment? And we talk about different nutritional tips to manage those. Other things that I might suggest to patients would be to eat more frequently so that they can, if they're not eating their, 3 regular meals, which are pretty standard, they can eat more frequently to make up for what they might not be eating in those regular meals. A lot of patients have questions about nutritional or protein shakes and which ones might work for them. So those are other strategies that patients can use to help with increasing their caloric intake. So there's a lot of just different strategies out there. And like I said, a lot of it's very individualized and based on how that patient is feeling and tailored to that patient, because each patient has very unique nutritional needs.
Thank you, Whitney. We do have some other questions from folks in our community. And Mindy, one of those questions is about infusions. So it seems like infusions are part of treatment that maybe some people don't really understand how they work. So can you talk to our viewers about what they can expect if they come to our infusion center, if someone they love needs treatment at our infusion center?
Sure. The first thing they need to know is that they're going to be well taken care of. When they come in, we're going to make them comfortable. We're going to explain everything that's individual to their treatment. If it happens to be a blood transfusion, the most important thing for people to know is that they have got to get their blood cross-matched with our blood bank. And they have to get their blood drawn in our second floor lab in our regional cancer center building. A lot of people are very confused about that because they've just had blood drawn at the doctor's office and don't really understand why they're having to come back to get it again. But that's for their safety, to make sure that we have the proper blood product available for them that they won't have a reaction to. For most infusions that are related to cancer and for blood transfusions, we give pre-medications that can vary in what they are, but the goal is to prevent them from feeling bad while they're with us or from having any reaction to the medication or to the blood. And then they'll just be with us for the duration of the treatment. We have drinks, snacks, TV, blankets, pillows. So really, everyone's scared to come to us, but once they get there and see what we're all about, then they relax and they know we're going to take good care of them.
Thanks, Mindy. And I can speak from personal experience. Those chairs are very comfortable. So no worries being able to sit there for a long period of time if needed. We do have another question in our live Q&A, and Deanna, I think you can speak to this. Some of our viewers are wondering if we have a relationship or resources available for experimental treatments or maybe clinical trials with other facilities in our region.
We do have a clinical research team here at Mary Washington, and we work with them for clinical trials. We also have the medical oncologist will guide with the clinical trials, and if there's something at a different facility, Duke, Johns Hopkins, any place else, we are more than happy to coordinate that care to get the patient to another facility. Yes, all the time, not a problem.
Thanks, Deanna. We are coming up to the top of our time for this evening, but I think we have time for just a couple more questions. Ted, I wanted to come back to you. You talked earlier about having your treatment locally. And as a survivor, looking back on your journey, how important was it for you to receive that treatment close to home?
Well, Emily, it was terrific because I really was 15, 20 minutes away from where I needed to go at all times. And during treatment, it doesn't always go as planned. I had trouble with my port a couple of times and had to come to the hospital for a port study, or you needed scans, you needed to come for some specialized blood work. And to have all of that nearby, I talked about being able to go to work every day. And that was partially because everything was all confined right here. And I think, and just to have family around and to have everything so nearby, it was, to me, it sure is never fun going through this, but I just felt like you just felt like everything was right here, and there was going to be no wasted time.
Great. Thank you, Ted. Another question that we have coming in is for Whitney. Whitney, if someone was interested in speaking with you about their dietary needs, during their cancer journey, how would they make an appointment with you?
Sure. The best way to reach me is actually through the nurse navigators. And the phone number for that is going to pop up on the screen now. So 741-1211. And like I said, I do get referrals from other sources too. So sometimes physicians will send patients over as well. You can speak to a physician as well if you're interested, but this would be the best way to contact me is through our navigators.
Thanks, Whitney. And then finally, just one more question to close us out for the night. Deanna, for someone who has a cancer diagnosis and goes through their journey and into survivorship, how long can someone use your navigator services?
Sure. There's no time limit. We are a free service for the community. So if I have some patients that I don't hear from for a while, and then they'll circle back around with me, there's no time limit. So yep, they're always welcome to call if they have questions or concerns.
Thank you, Deanna. And finally, Whitney, I know that you're hosting an upcoming live event about smoothies. I don't know anybody who doesn't love a smoothie. Can you talk to us a little bit about this event and what you'll be doing?
Yeah, sure. So yeah, we're hosting an event. It's actually next week over your lunch hour. It's a virtual event. So it's Tuesday, December 14th, and we are partnering with Kate Farms, the dietitian there, Laura Cunningham, and myself. She's actually going to be making smoothies out of their nutritional shakes, which are plant-based. And we're going to be talking about a plant-based diet and kind of defining what that is, and just kind of bringing some light to the benefits of different fruits and vegetables, and also herbs and spices and their use for, improving overall nutritional health.
Great. Thanks, Whitney. I hope that they have some recipes with turmeric and ginger. Those are my favorite. I don't know about you.
Those are good ones, definitely.
Yeah, a little spice. Never hurt anybody. All right, well, thank you so much for closing us out with that information, Whitney. And of course, a huge thank you to our panelists for making time to share your expertise this evening. And of course, I want to send a huge thank you to you, our viewers, for tuning in to this Ask the Expert event. If you have questions about hematologic cancer or want to learn more about Mary Washington Healthcare Services, we invite you to visit our website for additional resources. You can see that website up on your screen. You can find us online at cancer.mwhc.com. And be sure to watch the Mary Washington Healthcare Facebook page and other social media channels to stay informed of the latest health and wellness information for our community. Again, many thanks for joining us this evening. Please stay safe and healthy and have a good night.
Thank you.